Hello, my name is Mohammed Dilawadi, and today I present to you a case of acute epiglottitis as a presentation of COVID-19. Acute epiglottitis is a potentially fatal condition due to the high risk of respiratory failure from upper airway obstruction. The difficulty of managing the resulting upper airway obstruction via standard techniques such as rapid sequence intubation significantly contributes to the potential fatality. The etiology is most commonly infectious, although non-infectious etiologies have been identified, including thermal and caustic injuries, autoimmune diseases, and angioedema. We present a rare case of an episode of acute epiglottitis as a presentation of COVID-19 infection. A 37-year-old male with no significant medical history presented due to acute onset throat pain with difficulty swallowing that began the night prior. He denied any use of medications or supplements. He denied experiencing any dyspnea, subjective fevers, chills, or cough. The patient had no known sick contacts, previous history of similar symptoms, chemical inhalations, ownership of pets, recent travel, recent unprotected sex, or any known allergies. He had never received vaccination for COVID-19. He did report occasional but not daily smoking of cigarettes and marijuana, did not regularly consume alcohol, and denied any other illicit drug use. The patient was found to be febrile of 40 degrees Celsius, tachycardic at 105, and normotensive with a BMI of 22. He had hot potato voice and swelling and tenderness in the submandibular area with tender cervical lymphadenopathy. Lung fields were clear to auscultation. He was having difficulty swallowing solids, liquids, and his saliva, but appeared in no acute respiratory distress. An anteroposterior chest X-ray revealed clear lung fields and no abnormalities. A CT of the neck with intravenous contrast, as shown in Figure 1, revealed findings concerning for epiglottitis and laryngitis. If we look at Figure 1, we see a sagittal view of the CT neck with IV contrast and the demonstrated thickening of the epiglottis as well as the larynx, particularly the right posterior lateral laryngeal wall. And the yellow arrow indicates the classic thumb sign of epiglottitis. Labs were remarkable for leukocytosis of 16,800 with neutrophilic predominance, lymphopenia, monocytosis, and no eosinophilia. A nasopharyngeal swab PCR was positive for SARS-CoV-2 and negative for influenzas A and B and RSV. Rapid group A strep throat swab was negative. Serology was negative for HIV-1, HIV-2, EBV, and CMV. Blood cultures showed no growth after 5 days. He had mild elevation in transaminases with an ALT of 46, AST of 53, and an elevated highly sensitive CRP. He was admitted to the ICU and treated with IV Decadron or dexamethasone, piperacillin tazobactam, vancomycin, and crystalloid fluids. Flexible laryngoscopy revealed a severely swollen epiglottis with no vocal cord paralysis. After 5 days of close monitoring, the patient continued to not require intubation or any other airway intervention. He experienced some improvement as he tolerated a liquid diet. He was discharged home and instructed to take amoxicillin clavulanate for 7 days. Including this case, a total of 18 cases of acute epiglottitis associated with COVID-19 infection have been reported. Bacterial superinfection as an etiology cannot be ruled out. The incidence is likely underestimated due to potential misdiagnosis as pharyngitis of milder cases and overlap of symptoms with other airway disease when patients are severely ill or intubated. Clinicians should be aware of this condition due to the high risk of airway compromise and mortality without prompt diagnosis and appropriate management. Early involvement of skilled providers is critical as patients may require nasotracheal intubation, tracheostomy, or emergent cricothyrotomy. Thank you for your time and attention.